Hello everyone. So we are starting with neurological disorders. We're continuing epilepsy and table 29.1, some epilepsy syndromes, arranged by age of onset, infantile spasm West syndrome, 3 to 12 months, violent plexus spasm of the head, trunk, and limb followed by extension of the arms, last 1 to 2 seconds, often multiple bursts of 20, 30, often on waking or many a times a day. Maybe misindependence and colic, social interaction often deteriorates, visual marker in the history. Most have underlying neurological cause, e.g., hypsarrhythmia. Treatment is vigabatrin or corticosteroid, good initial response in 70%, but unwanted side effects of therapy and relapse is common. Most will lose skills and develop learning disability in continuing epilepsy. Lennox-Gastaut syndrome, 1 to 3 years, multiple seizures, side one mostly atonic, atypical subtle absences, and tonic seizures in sleep. Also, neurodevelopment, arrest or regression in behavioral disorder, many causes and often other complex neurological problems or history of infantile spasm. EEG shows slow generic spike and wave, 1 to 25, prognosis is poor. Childhood absence epilepsy, 4 to 12 years, momentary, unresponsive stare with motor rest, may twitch the eyelids or a hand or mouth minimally. Sudden onset lasts only a few seconds, less than 30 seconds. Child has no recall except realizes they have missed something and may look puzzled or say pardon on regaining consciousness. Developmentally normal but can interfere with schooling, accounts for only 2% of childhood epilepsy. Two-thirds of female episodes can be induced by hyperventilation, blowing on a piece of paper or windmill for 2 to 3 minutes. Useful during EEG. The EEG shows fast generalized spike and wave. 3 to 4 discharges bilaterally synchronous during and sometimes between absences. Prognosis good with 80% mentioned in adolescence. A few evolve into juvenile absence and juvenile myoclonic epilepsy. And epilepsy with centrotemporal spikes, childhood Rolandic epilepsy in 4 to 10 years of age, and tonic-clonic seizures in sleep or simple focus seizures when awareness of abnormal feelings in the tongue and distortion of the face supplied by the Rolandic centrotemporal area of the brain. 15% of all childhood epilepsies. EEG shows focal sharp rays from the Rolandic area, important to recognize as relatively benign and may not require AEDs, and it remits in adolescence. Beniotopolis syndrome, early onset benign occipital 1 to 5 years of onset, and autonomic features vomiting and unresponsive staring in sleep with head and eye deviation progressing sometimes to a convulsive seizure. Comprises 5% of childhood epilepsy. EEG shows stereofocal sharp waves and occipital discharges when eyes are shut. Remits in childhood, some have specific learning difficulties, and juvenile absence epilepsy 10 to 20 years, absences in generalized tonic seizures often with photosensitivity, learning is unimpaired. Characteristic EEG response to treatment is usually good but lifelong remission unlikely. Juvenile myoclonic epilepsy in 10 to 12 years, myoclonic seizures, generalized tonic seizures and absence seizures may occur mostly shortly after waking. A typical history is throwing drinks or cereal about in the morning as myoclonus occurs at this time. Learning is unimpaired. Characteristic EEG response treatment is usually good, but lifelong remission is unlikely. Now, this is the EEG of hypsarrhythmia and infantile spasm West syndrome. This is a chaotic background of slow wave activity with sharp multifocal. This is the EEG of a typical absence seizure in childhood absence epilepsy. This is 3 per second spike and wave. The discharge, which is bilaterally synchronous during and sometimes between attacks. Diagnosis of an epilepsy is primarily based on detailed history from the child and eyewitnesses, substantiated by video if available. This is increasingly provided on mobile phones. Particular attention is focused on any is focused on sorry, excuse me. It's focused on any specific triggers, and if the child has any impairments, as there may be educational, psychological, social problems. Clinical examination should include checking for skill markers for a cutaneous syndrome, or neurological abnormalities. Although epilepsy is really genetic idiopathic, it may be the presentation of a complication of an underlying neurological disorder. Investigation, remember, not all seizures are epileptic. ECGs, remember, in 12 standard ECGs done in children with seizures, especially convulsive seizures, even when an epilepsy seems most likely as a consequence of missing convulsive syncope due to arrhythmia. Long QT can be avoidable. Fatality. Sorry. Long QT syndrome can be an avoidable fatality. Okay. EEG, electroencephalogram. An interictal EEG is indicated whenever an epilepsy is diagnosed. It can help categorize epilepsy type and severity. If seizures are frequent, then an ictal EEG can make the diagnosis in suspected child or absent epilepsy and suspected infantile spasm, which is West syndrome. And if the standard interictal EEG is normal, sleep or sleep-deprived record can be helpful. Additional techniques are 24-hour ambulatory EEG or a 5-day video telemetry EEG for assessment prior to surgery. More invasive techniques such as intracranial electrodes can be used. Brain imaging, structural MRI, CT, brain scans are usually required routinely for childhood epilepsies unless there is a characteristic history of childhood absent epilepsies, juvenile absence epilepsy, juvenile myoclonic epilepsy, or childhood epileptic epilepsy. MRI fluid attenuated inversion recovery flare sequences are better at detecting mesial temporal sclerosis in temporal lobe epilepsy, which can sometimes be surgically cured. Functional, while it is not always possible to see structural lesions. Technique have advanced to allow functional allow to functional to allow functional imaging to detect areas of abnormal metabolism suggestive of epileptogenic zones. These include PET positron emission tomography and SPECT single photon emission computed topography, which uses isotopes and ligands injected and taken up by metabolically active cells. Both can be used between seizures to detect areas of hypometabolism in epileptogenic lesions. Ictal SPECT can locate areas of hypometabolism during epileptic seizures, and they are used in the workup of patients for possible epilepsy surgery. Other investigations, metabolic investigation will be indicated if there is developmental arrest or regression. If she's related to feeds or fasting, it should be considered in epilepsies, not including febrile seizures. Starting the first 2 years of life, genetic tests are becoming increasingly useful, especially in intractable epilepsy with developmental arrest or delay. Epileptic and developmental encephalopathies management begins with diagnosis, but this is often uncertain initially. The uncertainty needs explaining and a plan put in place to ensure the child's safety until more information, for example, for investigation of parental video kits is available. Once diagnosed, a clear explanation of the diagnosis and advice to help adjustment of the conditions needed. Factors replacing nurse versus families are providing education and continuing advice on lifestyle issues. The decision whether to treat or not is related to the risk of recurrence, how dangerous or impairing, and how upsetting further seizures would be. In the context of child or young person's life, it is common practice not to institute treatment for typical childhood renting epilepsy, and treatment of childhood absent epilepsy is aimed at maximizing their educational potential and supporting their social development. Anti-epileptic drug therapy principle of governing not all children with epileptic seizures require anti-epileptic drugs therapy. The decision should be based on the seizure type, epilepsy type, frequency, and the social and educational consequences of seizures set against the possibility of unwanted effects of AED. Choose an appropriate AED for the seizures and epilepsy. Inappropriate manipulated drugs may be detrimental. Carbamazepine can make absent seizures, absent mind-blowing seizures worse. I think Maze was absent seizures. I don't know. Okay, might be myoclonic as well. Monotherapy at the minimum dosage to prevent the seizures without adverse effects is a desired goal, although in practice more than one AED may be required. All AED have potential unwanted effects, and these should be discussed with child and parent. AED levels are not measured routinely, but may be useful to check concordance, adherence, or the use of a dose. These could be considered high doses, not working. Childhood with prolonged epileptic seizures, convulsive epileptic seizures with loss of consciousness more than 5 minutes, and need rescue therapy to keep with them. This is usually buccal midazolam. AED therapy may be discontinued after 2 years free of seizures. As said, usually be continued indefinitely in young people with juvenile absence seizure, juvenile myoclonic epilepsy. Guidance regarding treatment options for different seizure types. Common unwanted effects of are shown. Okay, we'll do this. Under treatment options, children with intractable epilepsies, there are a number of other treatment options. Ketogenic and low-carb fat-based diets may be helpful in some children. Vagal nerve stimulation delivered using externally programmable stimulation of a wire implanted around the afferent. Deaf figures may be helpful in some children. Epilepsy surgery, sedation of seizure, and the AED therapy may be achieved in some children whose epilepsy is well localized, structural cause, or epileptogenic. Tone has demonstrated by good concordance between ictal EEG, MRI, and functional imaging. So the main procedure is temporal lobectomy for mesial temporal sclerosis, but other procedures include hemispherotomy, disconnection of the hemispheres, and other focal resection. By some purposes, they aim to promote independence and confidence. Subject of epilepsy in the family needs psychological help to adjust to the condition. The school needs to be aware of the children's problem and teacher advise the management seizures. Unrecognized absences may interfere with learning, which is an indication for being vigilant about part episodes, which may be epileptic seizures. Particularly few restrictions are required. The situation where having a seizure could lead to injury or death should be avoided. This includes avoiding deep baths. Showers are preferable and not swimming unsupervised. For adolescents, there will be issues to discuss around driving only after 1 year free of seizures, contraceptions, and pregnancy. There will be also issues with concordance, adherence, and the precipitation of seizures, and while good and poor sleep patterns. And valproate is also teratogenic. Choice of anti-epileptic fluid, valproate, and carbamazepine. As second line is clobazam, levetiracetam, and topiramate. Absence seizure has first line is valproate and ethosuximide. And second line is the same. Valproate is valproate, levetiracetam, and second line has clobazam, piracetam, and clomazepam. Focal hair carbamazepine, valproate, levetiracetam, and lamotrigine, and the second line is clobazam, topiramate, lacosamide, and gabapentin. For carbamazepine and gabapentin, it is that avoid with absent seizures, myoclonic seizures in juvenile, myoclonic epilepsies. Avoid in females is valproate, child in potential if possible. As it is teratogenic, common, important, unwanted effect. Valproate is weight gain, hair loss, teratogenic, rare, idiosyncratic liver failure. Carbamazepine rash, ataxia, liver enzyme induction can reduce the effect of oral contraception, lamotrigine rash, insomnia, ataxia. Ethox has nausea and vomiting, levetiracetam irritability. Sorry, excuse me. GABA has insomnia, topiramate, weight loss, depression, paresthesias, vigabatrin, irritability, visual feature restriction limits is used mainly to infantile spasms. Sudden unexpected death in epilepsy is very rare in childhood, may be discussed in its rarity emphasized. Information is available from self-help groups and organizations such as Epilepsy Action. Children with epilepsy do less well educationally, so social outcome and with future employment than those with other chronic illnesses such as diabetes. Two-thirds of children with epilepsy go to mainstream, but some require educational help and associated learning difficulties. One third attend a special school, but they often have multiple disabilities, and the epilepsy is part of severe brain disorder. A few children require residential schooling, homeschooling, where there are facilities and expertise in monitoring and treating intractable seizures. Valproate is the ventriloquogenic. Studies epileptic established serial practicing epileptic seizure lasting 30 minutes, repeated epileptic seizure for 30 minutes without recurring consciousness described in pediatric emergencies. Emergency treatment is best given about 5 minutes of a convulsive epileptic seizures. After about 5 minutes, incipient convulsive status epilepticus. Facts 1 and 200 classifies according to seizure type, epilepsy type, and underlying etiology. An interictal EEG is performed whenever an epilepsy is diagnosed to help to categorize epilepsy type. Excuse me. An ictal EEG may make the diagnosis. AD therapy is should be considered with the seizure intrusive and selected according to seizures and epilepsy type. Monotherapy is given if possible and chosen for the least potential adverse effects. Requires liaison with school about how to manage the seizure and avoiding situations which could lead to injury. Motor disorders. Motor disorder movement is governed by cerebral control centers. Patterns of information modulated by afferent sensory information, joint position, fluid touch, visual, auditory, vestibular, pass down the brainstem and spinal cord through synapses and anterior horns and along peripheral nerves to target muscles. In clinical practice, the first question to ask when seeing a child with motor disorder is whether there's a central peripheral nervous system disorder. The pattern of movement usually gives the answer. Causes of movement disorders is this and central motor. So three central motor control centers are motor cortex, basal ganglia, cerebellum. Motor cortex lying along the precentral gyrus. The homunculus reflects the body upside down, legs superiorly and facing freely, just above the cerebral fissure, with large areas to be on 5 movements of tongue, fingers, and thumb. Information from here passes down the corticus pyramidal tracts and links with the basal ganglia. Deep gray matter structures store pattern of movement so that we need not put conscious effort into every movement we make. Cerebellum controls posture, balance, coordination, and speech. Disorders of central corticospinal pyramidal disorders, there is weakness in the pattern of adduction of the shoulder, flexion at the elbow, pressure of the arm, adduction and internal rotation of the hip, extension at hip and knee, and plantar flexion at the ankle, with brisk hyperreflexia and extensive plantar reflexes, fine finger movements will be lost. Basal ganglia disorder will lead either to difficulty initiating movement, with fluctuating, largely increased tone, a dystonia, dyskinesia, where packets of movement information are released to give jerky movements, chorea, or rhythmic movements at ptosis. Cerebellar disorder will lead to difficulty holding a posture, pass pointing, dysmetria, and dysdiadokinesia, poor alternating movements. Um, and the gait is wide based and ataxic. Posterior column sensory pathway problems may give a similar clinical picture, but with even worse ataxia when the eyes are closed, but are much rarer in childhood. Associated mixed segments and characteristics scanning dysarthria may be seen. Causes of these disorders are listed. Cerebral palsy is described in chapter 2, the mental problems with special needs. Corticospinal and pyramidal tract disorders, acquired brain injury, cerebral dysgenesis, cerebral dysgenesis, neuronal migration disorder, global hypoxia, ischemia, and arterial ischemic stroke, cerebral tumor, acute disseminated encephalomyelitis, Adam, and post-ictal thoughts paresis, and hemiplegic migraine. Basal ganglia disorder, acquired brain injury, acute and profound. Hypoxia ischemia, carbon monoxide, post-bypass surgery, chorea, post-streptococcal chorea, rheumatic fever, mitochondrial disease, Wilson disease, Huntington disease, acute intoxication, colon carbamazepine, post-viral varicella, posterior fossa lesion, medulloblastoma, genetic disorder, febrile ataxia, and ataxia, telangiectasia, peripheral motor disorder, neuromuscular disorders, any part of the low motor neuron pathway can be affected in neuromuscular disorders, including inferior horn cell disorders, peripheral neuropathies, disordered neuromuscular transmissions, and primary muscle diseases. The cause of neuromuscular disorders shown. The key clinical feature of neuromuscular disorders is weakness, which may be progressive or static. Affected should may result in hypotonia, floppiness, delayed motor milestones, muscle weakness, unsteady abnormal gait, fatigability, muscle cramps, suggesting a metabolic myopathy. History and examination may provide useful clues. Children with myopathy often show a waddling gait or positive Gower sign, suggestive of proximal muscle weakness. Gower sign is a need to turn prone to rise to standing firm from a supine position. This is normal until the age of 3 years. It is only when children have become very weak that they climb up the legs with the hands to gain the standing position. Pattern of more distal wasting and weakness, particularly in the presence of pes cavus, suggests a hereditary motor sensory neuropathy. Increasing fatigability through the day, often with ophthalmoplegia and ptosis, suggests a disorder of the motor end plate, neuromuscular junction, that is myasthenia gravis. Anterior horn cell, there are signs of denervation, weakness, loss of reflexes, fasciculation, wasting as the nerve supply to the muscle fails. Neuropathy, often longer nerves affected. Motor neuropathy will give weakness. Sensory neuropathy will give impaired perception of pain and temperature or touch. With the loss of reflexes in both myopathy, there is weakness, often proximal wasting and gaze disturbances. Neuromuscular junction as end-plane acetylcholine stores become depleted. There is diurnal worsening through the day, leading to fatigability. Investigation, myotherapy, myopathy, plasma creatinine, creatine kinase, markedly elevated in Duchenne and Becker muscular dystrophy, congenital muscular dystrophy, many limb girdle muscular dystrophies, inflammatory myopathies. And DNA testing for abnormal genes, ultrasound and MRI muscles used to diagnose and monitor progress, muscle biopsy, modern histochemical techniques often enable a definitive diagnosis. This was Gower sign. And disorders of anterior horn, spinal muscular atrophy, polio, acute flexus myelitis, enterovirus D68, disorders of peripheral nerve, hereditary motor sensory neuropathy, acute post-infection polyneuropathy, Guillain-Barré, and Bell palsy. Disorders of neuromuscular transmission is myasthenia gravis, muscle disorders, muscle dystrophies, Duchenne, Becker, and congenital inflammatory myopathies are benign. Acute myositis, polymyositis, and dermatomyositis. Myotonic disorders are myotonic dystrophies and metabolic myopathies, congenital myopathies, and this is also Gower sign. The child needs to turn prone to rise. The key early feature then uses his hand to climb on his knees before standing. Late feature because of poor hip girdle fixation or proximal muscle weak. Any child continuing to turn prone to rise after 3 years of age is likely to have a neuromuscular condition. Neuropathy, DNA testing for abnormal genes, nerve connection studies to identify delayed or diminished motor and sensory nerve connection losses seen in neuropathy, EMG electromyography helps in differentiating myopathic from neuropathic disorders, fatigability on repetitive nerve stimulation, myasthenia, nerve biopsy occasionally performed by removing segment of spinal nerve in the calf. Diagnosis of neuromuscular disorders have been made easier by advanced genetic DNA testing for spinal muscular in SMA. For SMA and Duchenne muscular dystrophy, myotonic dystrophy, and the congenital muscular dystrophy, limb-girdle muscular dystrophy, and hereditary neuropathies. Disorders of anterior horns, presentations with weakness, wasting, and absent reflexes. Polio has almost been eradicated globally by immunization. Except two countries, spinal muscular atrophy is autosomal recessive degenerations of the anterior horn cells leading to progressive weakness and wasting of skeletal muscles due to mutations in survival motor neurons, SMN1 gene. This is the second most common cause of neuromuscular disease in the UK after Duchenne muscular dystrophy and affects 1 in 6,000 to 10,000 live births. Number of phenotypes are recognized. Spinal muscular atrophy type 1, Wednick-Hoffman disease, a very severe progressive disorder presenting from birth to 3 months of age. Diminished fetal movements are often noticed. During pregnancy, there may be graposis, positional deformities of limb, and with contractures of at least two joints at birth. Typical signs are alert expression, fasciculation of the tongue, symmetrical flexor paralysis, absent deep tendon reflexes, intercostal sessions, weakness of the bulbar muscle causing weak cry, and poor suck with pooling of secretions. This is spinal muscular atrophy type 1, Woodning-Hoffman showing proximal muscle wasting, and chest deformity from weakness of intercostal muscles and thighs held adducted because of hypotonia. And untreated, the natural history comprised death from respiratory failure within about 12 months of age. However, recent innovative treatment affecting gene expression have been shown to be effective and now available in countries that can afford them. The first of these treatments are nusinersen, targeted closely related but partially functioning gene SMN2 by preventing exon skipping. It increases production of SMN2 gene, and this ameliorates the clinical expression of SMA in some children. Gene therapy has recently proved successful in young children, but all these new treatments are very expensive. These are milder forms of disorders with a later onset. Children with type 2 SMA present at age 3 months to 15 months and can sit but never walk independently. Those with a milder type 3, present after 1 year of age and do learn to walk. Most severe form is SMA type 0 and is diagnosed in newborn infants that are born so weak that the survival have been limited to only a few weeks. The place of the treatment described above is yet to be established. Peripheral neuropathy, Charcot-Marie-Tooth disease, the hereditary motor sensory neuropathy. There are many forms of Charcot-Marie-Tooth disease, which typically leads to symmetrical, slowly progressive distal muscular wasting. They are caused by mutations in myelin genes. CMT1A accounts for 70 to 80% is inherited in an autosomal dominant manner in two-thirds. One-third developing the mutation node. Other types of CMT disease can be inherited by autosomal dominant. Recessive and X-linked modes. Children may present preschool with tripping from bilateral foot drop. Examination shows loss of ankle reflexes progressing to loss of knee reflexes. Prescavis may present the lower limbs being affected more than the upper nerve connection studies show motor and sensory neuropathy. Affected nerves may be hypertrophy due to demyelination followed by attempts of at demyelination. The disease is chronic, but only really do those affected lose the ability to walk. The initial presentation of fatigue ataxia can be similar Gyan by acute post-infectious polyneuropathy. Now, the GB syndrome can occur at any age. It typically presents 2 to 3 weeks after after an upper respiratory tract infection or Campylobacter gastroenteritis with an ascending progressive symmetrical weakness over a few days to 2 weeks. There's a loss of tender reflexes and autonomic involvement. Sensory symptoms, usually in the distal limb or trunk, are less striking than the weakness and can be unpleasant. When present, a bilateral facial weakness is easily missed in young children. Involvement of bulbar muscles lead to difficulty with chewing and swallowing and the risk of aspiration. Dysautonomia occurs in 70%, manifests as tachycardia, bradycardia, and other arrhythmias, hypertension, orthostatic hypertension, urinary tension, ileus, and loss of sweating. Hyperventilation can require artificial ventilation, best started before established respiratory failure. The maximum muscle weakness may occur only 2 to 4 weeks after the onset of an illness. Although full recovery can be expected in 90% of cases, this may take up to 2 years. MRI of the spinal cord, brain, and spinal cord is the most useful acute investigation to identify or exclude a spinal cord lesion, bleed, tumor, inflammatory transverse myelitis. CSF white count is not raised, but CSF proteins characteristically markedly raised. However, this may not be seen until the second week of illness. Nerve conductor surgery typically show reduced velocity, but this may not be evident until after the second week. Management supported, particularly respiration. The disorder is probably due to formation of antibody attaching itself to protein components of myelin. Corticosteroid have no beneficial effect and may delay recovery. Controlled trials indicate that recovery is more rapid with IV, IG infusion, and plasma exchange. Bell palsy and facial nerve palsy. Bell palsy, an isolated low motor neuron paresis of seventh cranial nerve leading to facial weakness. Etiology is often unclear, although it is sometimes caused by post-infection inflammation associated with herpes simplex virus or Lyme disease. Herpes virus or infection of the geniculate ganglion can cause painful vesicles on the tonsillar fauces and external ear. With the facial nerve paresis, if herpes is suspected, treat with acyclovir. Corticosteroid can reduce any facial nerve inflammation and swelling of the facial canal if given during the first week, and speed full recovery. Recovery is incomplete in the majority of cases but may take several months. The main complication is conjunctival infection due to incomplete closure on blinking. This may require the eye to be protected, lubricating drops or ointment patch, or even tarsography. There are important differential diagnoses. There is also recent six nerve paresis or ipsilateral cerebellar signs or contralateral upper motor neuron signs. Suspect this Bell's left facial weakness of both upper and lower face. Suspect for brain stimulation. If there are symptoms of recent eighth nerve paresis, most likely diagnosis of compression in the cerebellopontine angle. Hypertension should be excluded as there is an association between balance and coarctation of aorta renal failure. Disorder of neuromuscular transmission myasthenia. This presents abnormal muscle fatigability with improved rest or anticholinergic drugs. Juvenile myasthenia to adult autoimmune myasthenia gravis and is due to binding of antibody to acetylcholine receptors on the postsynaptic membrane of the neuromuscular junction. This reduces number of function receptors. Presentation is usually after 10 years of age, with ophthalmoplegia and ptosis, loss of facial inspection, difficulty chewing. July, especially proximal weakness may be seen. Diagnosis made by observing improvement following the administration of IV atrophonium over a few minutes or oral pyridostigmine or neostigmine over days, identifying acetylcholine receptor antibodies seen in 60 to 80% or more, rarely anti-muscle specific kinase. Antibodies will confirm diagnosis and direct treatment decisions. Treatment is with the choline esterase inhibitors, pyridostigmine or neostigmine, and immunosuppressive therapy, immune modulating drugs such as prednisolone, azathioprine, or mycophenolate, mofetil, or even monoclonal antibody biologicals. Rituximab are of value. Thymectomy is indicated if a thymoma is present or in a young antibody positive patient with a very acute severe presentation affecting more than just ocular muscle plasma series 5-6. Congenital myasthenic syndromes. There are rare genetic syndromes which causes neuromuscular junction failure and newborn death. Features may include ptosis, ophthalmoplegia, and bulbar and respiratory muscle weakness and arthrogryposis. These disorders do not always respond to anticholinesterase inhibitors. This myasthenia, ptosis, and ocular muscle fatigue is improved with Endophobia. Muscle disorder, muscular dystrophy. This is a group of inherited disorder, progressive muscle degeneration, DMD, affects in 1 in 3,000 to 6,000 male infants. It is an X-linked recessive disorder, although about a third of boys have de novo mutation, results from deletion of gene of dystrophin, which connects the cytoskeletal muscle fiber to the surrounding cellular matrix through the cell membrane, where it is deficient. There is gradual progressive myofiber necrosis. Some countries, but not the UK, have neonatal screening programs. Affected children are detected by an elevated plasma creatine kinase. And in countries without screening, presentation is often with a waddling gait and language delay. They have to mount stairs one by one and run slowly compared with their peers. Although the average age of clinical diagnosis remains 5 years, children often have symptoms and signs much earlier. They will show Gower signs they need to turn prone to rise over the age of 3 years. There is pseudo-hypertrophy, a large wither calves because of replacement of muscle fibers by fat and fibrous tissue. In the early school years, affected boys tend to be slower and clumsier than their peers. Progressive muscle atrophy and weakness means that they typically are no longer able to walk by the age of about 10 to 14 years. Life expectancy is reduced to the late 20s, and from respiratory failure or associated cardiomyopathy, about one third of affected children have learning difficulties. Scoliosis is a common complication. Management physiotherapy, splinting of the ankles, help to prevent contractures, decrease tensile lengthening, and scoliosis surgery may be required. Weakness of respiratory and upper airway muscles may lead to sleep disordered breathing if undetected and untreated. This may cause daytime headache, irritability, and loss of appetite. Symptoms are highly variable. Boys who are no longer able to walk should have regular sleep studies, overnight CPAP, continuous positive airway pressure, or non-invasive positive pressure ventilation may be provided to improve the quality of life. Corticosteroid may help to preserve mobility and prevent scoliosis. The precise mechanism by which glucocorticoids help is not known. Innovative molecular genetic therapies are becoming available, including exon skipping drugs, which can bypass the effect of some mutations, leading to production of a small amount of dystrophin and a milder phenotype. Becker muscular dystrophy is allelic with Duchenne, caused by different mutation in the same gene, but some functional dystrophin is produced. And the features are similar to those of DMD, but clinically the disease is milder, progressive more slowly. The average response is 11 years. Loss of independent ambulation is in the late 20s, with life expectancy well into middle or old age. And limb girdle, these conditions present with proximal, upper and lower limb weaknesses, cardiomyopathy, and difficulty with breathing may be associated with some. These conditions can have different modes of inheritance. Plasma creatine kinase is usually congenital muscular dystrophies. They have autosomal recessive inheritance and most present at birth or in early infancy, with weakness, hypotonia, and contractures. Typically, proximal weakness is slowly progressive with a tendency to contracture when the ability to walk is lost. Feeding difficulties and breathing difficulties may occur in some cases. Some may run a more static course. Muscle biopsy shows dystrophic features with reduction of one of the extracellular matrix proteins, such as laminin, or one of the several glycosyl transferases. Some congenital muscular dystrophies have associated central nervous abnormalities causing intellectual disabilities. Congenital myopathy, these conditions present at birth or infancy with effects primarily affected skeletal muscle fibers, causing muscle weakness or hypotonia. They are static or slowly progressive. They are named according to the changes seen on muscle biopsy or electron microscopy. Plasma creatine kinase is normal or on only mildly elevated. Metabolic myopathies, metabolic conditions can affect muscles due either to the deposition of storage material or to energy depleting enzyme deficiencies. Presentations as a floppy infant or in older children with muscle weakness or cramps on exercise. Main causes are glycogen storage diseases, disorders of lipid metabolism. Fatty acids are important muscle fuel. Fatty acid oxidation occurs in mitochondria and effects in the pathway can result in weakness. Carnitine, palmitoyl transferase CP3, CPT2 deficiency is the most frequent disorder of Lipid metabolism. Defect of fatty acid oxidation can cause a secondary deficiency in carnitine. Mitochondrial cytopathies, rare disorders caused by mutation in the gene for mitochondrial protein involved respiratory chain function can be caused by mitochondrial DNA mutations, which are maternally inherited, or nuclear DNA mutations, mostly recessive or X-linked. Myopathy can be a major manifestation on the disorder, may be multisystem electric acidosis, encephalopathy. Mutation is also responsible and mode of inheritance should be determined. Inflammatory myopathy is benign acute myositis. This is assumed to be post-viral and runs a self-limiting course. Pain and weakness occurs in affected muscle. Plasma kinase is usually raised. This is pink purple rash and dermatomyositis. These are intracranial hemorrhages. We are done with it almost. Okay, there's a bit left. You guys want to continue or should we stop there? We can do ataxia later. Okay. Okay, let's finish motor diseases and dermatomyositis. This is something called progression dermatomyositis. This is stomach illness and probably due to an angiopathy. Onset is usually between 5 to 10 years of age. This can be acute, but more typically is insidious with fever, misery, and eventually symmetrical muscle weakness, which is mainly proximal, sometimes pharyngeal muscle involvement, affects swallowing. Muscle pain is common in arthritis may occur. There is also characteristic violaceous pink purple rash on the eyelids and periorbital edema. The rash may also affect the extensive surface of joints, elbow, and with time subcutaneous lubrication, calcinosis can appear. Inflammatory markers CRP, ESR sometimes raised, and CK2C is raised. Muscle biopsy shows an inflammatory cell infiltrate and atrophy. Physiotherapy is needed to prevent contractures, corticosteroids, and other immunosuppressants, methotrexate, cyclosporin. Mean needed mortality is 5 to 10%. Myotonic disorders is delayed relaxation after sustained muscle contracture. It can be identified clinically in bioimagery. Dystrophia myotonica type 1. This relatively common illness is dominantly inherited and caused by nucleotide triplet repeat expansion CTG in the DMPK genes. So this means it can be anticipation through generations, especially when maternally transmitted. Newborns with congenital myotonic dystrophy can present a hypotonia, feeding, and respiratory difficulties due to muscle weakness. They can have thin celipes at birth and together with oligohydramnios and due to muscle together with oligohydramnios and reduce fetal movement pregnancy, it is then useful to examine the mother for myotonia. This manifests as slow release of handshake with difficulty releasing tightly clasped wrist. This may be mild and not previously noticed. Sensitivity is required as diagnosis in a unit may have repercussion for the family. However, making the diagnosis in the family members can help to reduce the risk of potential complications such as cardiac dysrhythmias and aesthetic complications. Older children can present with the myopathic facial appearance, learning difficulties, and myotonia. Adult develops cataracts in males develop baldness, testicular atrophy, and type 2 diabetes. Death is usually due to cardiac conduction defects. The hypotonic floppy infant. Persisting hypotonia can lead to readily felt on picking up the infant who tends to slip through the fingers, hang like a rag doll when suspended phone. There's a marked head lag with the infant is pulled towards by the arm from the spine. From spine, this causes a list. The causal list is the clinical examination may help determine. This is myotonic dystrophy in 8-year-old who has marked facial weakness and moderately severe learning difficulties. Help determine the site of the lesion. Whether cerebral or neuromuscular, central hypotonia is associated with poor truncal tone but preserved limb tone. Dysmorphic features suggest a genetic cause. Low motor neuron lesions are suggested by frog-like posture, poor anti-gravity, and absent tendon legs. We can do ataxia too. It's just ataxia causes cerebral ataxia listed. Both unsteadiness or posture and movement can also be caused by disorders of the inner ear labyrinth. And sensory nerves and dorsal columns of the spinal cord muscle weakness are seen in someone with functional neurological symptoms and signs. Pediatrics is autosomal recessive fatigue due to triple repeat and affected exon gene and causing a lack of frataxin protein. It presents with worsening ataxia, arthritis, wasting in the lower nerves with absent flexing and pescavis. It is similar to CMT disease, Charcot-Marie tooth disease, but in fact, ataxia there is impairment of joint position and vibration sense. The posterior column affected extensor plantars indicating pyramidal involvements and typically optic atrophy. The cerebral component becomes more apparent with age, evolving kyphoscoliosis, diabetes mellitus, and cardiomyopathy can cause cardiorespiratory compromise at the age 40 to 50 years. Ataxia selected disordered DNA repair is autosomal recessive and gene codes for a protein kinase mutation, which, among other things, is involved in repairing double-stranded DNA breaks. There is a mild delay in motor development, rudeness and coordination of eye movements, and delay in ocular pursuits, and saccades, moving eyes to target, difficulty with balance, coordination, speech become evident in primary school. There is subsequent deterioration, which with many children requiring a wheelchair. This is a floppy baby of hypotonia, vertical suspension held upright, and then arms. The hypotonic infant slides to one hand on the ventral suspension. The infant flops like a rag doll. This is rag doll, and on this marked head lag. This is called hypotonia. Central hypotonia. Cerebral malformation is the causes: ischemia, hemorrhage, hypoxic ischemia, encephalopathy, intracranial hemorrhage, metabolic endocrine, hypothyroidism, binary metabolism, chromosome syndrome, facial dysmorphia, trisomy 21, prader-Willi, and other, and peripheral hypoxic spinal cord. Anterior spinal SMA type 1, Wendling Huffman, neuromuscular, neonatal myasthenia gravis, muscle congenital myopathies, and myotonic dystrophy. Global hypotonia, weak or absent anti-gravity movements of severe muscle weakness and reduced tender reflexes. Global hypotonia has anti-gravity movements present, normal or increased peripheral tone, wrist tendon reflexes, features of brain dysfunction may present, seizure, poor visual contact, facial dysmorphism, chromosomal syndrome. And this is telangiectasia of the conjunctiva are present from about 4 years of age in ataxia genetic. Causes of cerebral ataxia: toxins, ethanol, drugs, carbamazepine, lamotrigine, post-infectious cerebralitis, varicella posterior fossa tumor, cerebellar genesis, dysgenesis, pediatric ataxia, ataxia telangiectasia, mitochondrial diseases, other hereditary cerebellar ataxia, and Miller-Fisher syndrome variant of GP syndrome. And that we were doing in the teens, telangiectasia development conjunctiva may occur in the neck and the shoulders and about 4 years of age. These children have an increased susceptibility to infection, deficiency of IgA and IgE, develop malignant esophageal lymphomas, acute leukemias, develop progressive pulmonary diseases with bronchiectasis, have a raised serum alpha protein, have sensitivity to ionizing radiation. Most will die of malignancy or chronic lung disease in their 20s. Cerebrovascular disease, intracranial hemorrhage, extracellular hemorrhage. This usually follows direct head trauma, often associated with skull fractures, dating of middle meningeal artery as it passes through the foramen spizozoid of the sphenoid node. It results from arterial venous bleeding into the extraarterial space. There is often a lucid interval until the conscious level deteriorates, and sometimes epileptic seizures secondary to expanding hematoma. There may be focal neurological signs, dilatation of the ipsilateral pupil, paresis of the contralateral limbs, and a false localizing unilateral or bilateral six nerve paresis. In young children, initial presentation may be may sorry may may be with anemia and shock. Diagnosis confirmed CT scan. Management is to correct hypovolemia, urgent evacuation of hematoma, rest of the bleeding. Subdural result from tearing or bridging veins as they cross the subdural space. Characteristic lesion is non-extent lynchy caused by shaking or direct trauma in infants or toddlers. Retinal hemorrhages are typical of shaking injury. Subdural hematomas are occasionally seen following a fall from a considerable height and rarely in associated with brain shrinkage through atrophy and overdrainage of hydrocephalus. Subarachnoid hemorrhage, this is much more common in adults. Presentation is usually with a severe headache with rapid onset, thunderclap, headache, vomiting, confusion, or decreased level of consciousness, sometimes epileptic seizures, and a coma. CT scan of the head usually identifies blood in the CSF. Occasionally, lung function is required, and the cause is often an aneurysm or arteriovenous malformation can be identified on MR angiography. CT or conventional angiography treatment can be neurosurgical or with interventional radiology. Now I see hemorrhage or history of significant head injury and extra that may present even with if loosened immediately afterwards. Subdural and retinal consider non-accidental issue by shaking or direct trauma. Stroke. Now, stroke is here, meningoceles, hydrocephalus, and you guys have to say because it's like the end of everything. It's very easy. We can just end it here, or you guys can. Stroke is very easy, so we can do it. Stroke, perinatal stroke described. Childhood stroke may be used to vascular thromboembolic or hemorrhagic disease. The clinical presentation is determined by the vascular territory involved. In arterial ischemic stroke, there is commonly compromise of the anterior circulation, internal carotid, anterior cerebral, and metacerebral, which leads to contralateral hemiparesis with or without heminopia and speech disturbance. The less common is compromise of the posterior circulation with vertebral basilar arteries associated visual or cerebellum. Its cause of stroke is cardiac, congenital, cyanotic heart disease, fellow tetralogy, and endocarditis. Symptomological sickle cell disease, deficiency of antithrombotic proteinase, post-infective following varicella and other viral infections, inflammatory damage to vessels, and autoimmune disease, SLE, and metabolic and genetic homocystinuria, mitochondrial disorders, myoclonic epilepsy, lactic acidosis, and stroke, MELAS, and cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, carousel vascular malformations, arteriovenous malformative, or Moyamoya disease, in which there is progressive involvement of cerebral arteries. Moyamoya comes from the Japanese from puff of smoke, similar to the blood appearance of or angiography. Trauma dissection of carotid vertebral artery investigation should include an assessment of cerebral and external carotid vasculature with MRI, MR-angio, and indicated MR venography. Echo detect a source of embolism along with thrombophilia and vasculitis screen. Metabolic test for homocystinemia, homocysteine, and mitochondrial cytopathy. Often no cause can be identified. Rehabilitation requires involvement of multidisciplinary therapy team. Low dose aspirin for 5 is recommended after arterial ischemic stroke. Occurs in infant children, infants occur in perinatal period and may present a late infant hemiplegia or epileptic seizures. In children are seen association with cardio or sickle cell disease following by cell infection, neck trauma, however, of no cause. Microcephaly were described in chapter 12. Neural tube defects and hydrocephalus. Neural tube defects result from failure of normal fusion of neural plate to form the neural tube during the first 28 days following following conceptions, and mother of the fetus with a neural tube defect has a 10-fold increase in risk of having a second affected fetus. The risk is also increased 10 to 20-fold mothers taking the anti-epileptic drug sodium valproate. Maternal folic acid supplementation during early pregnancy has been shown to reduce prevalence by 25 to 50%. In many countries, but not in the UK or most countries in Western Europe, cereal grain products are fortified with folic acid. The birth prevalence of neural tube defects has fallen dramatically 4,000 in the 1970s to 0.1,000 birth in 2018. The reason for the decline is uncertain and may be associated with improved maternal nutrition, mothers taking folate supplements pre and during pregnancy, and avoiding sodium valproate in pregnancy, together with antenatal diagnosis and the option of termination of pregnancy. This is prevalence and anencefali. This is failure of development of most of cranium and brain affected infants are stillborn or die shortly after birth. It is dissected or until screening termination pregnancy is usually offered. In encephalocele, there is extrusion of brain and meninges through a midline skull defect, which can be corrected surgically. However, there are often underlying associated cerebral malformations, spina bifida occulta. This failure of fusion of the vertebral arch is often an incidental finding on X-ray, but there may be an associated underlying skin lesion such as a tuft of hair, lipoma, birthmark, or small dermal sinus, usually in the lumbar region. There may be an underlying tethering of the cord. Diastigmatomyelia, which with growth may cause impairment in bladder and lower limb function. The extent of the underlying lesion can be delineated by ultrasound and/or MRI. Neurosurgical division of the tethering is usually indicated. Meningocele and myelomeningocele. Meningocele usually have a good prognosis following surgical repair. Myelomeningocele may be associated with variable paresis along with hypertonia, muscle imbalance, which may cause dislocation of the hip and telepiece, sensory loss, bladder denervation, neuropathic bladder, bowel denervation, neuropathic bowel, scoliosis, hydrocephalus from the associated Chiari type 2 malformation, herniation of the cerebral tonsils, cerebellar tonsil, basement tissues through the foramen leading to disruption of CSF. So this is spina bifida occulta, hair patch and skin, and neural tube reflex, spina bifida occulta, meningocele, skin and dura, pyelonephroid, and spinal cord is still inside, and neural plaque is myelomeningocele, neural tube is also outside, and this is myelomeningocele showing the exposed neural tissue and petalous anus from neuropathic bowel management. The back lesion is usually closed soon after birth. Paralysis, muscle imbalance requires physiotherapy to prevent joint contractures. Walking aids or wheelchair help mobility because of sensory loss. Skincare is required to avoid the development of skin damage and ulcers. Neuropathic bladder is managed with the indwelling catheter, intermittent urinary catheterization by parents or by older children themselves. There should be regular checks for hypertension, renal function, urinary infections. Prophylactic antibiotic may be necessary. Medication such as Ephedrine can improve bladder function and improve urinary dribbling. Bowel innervation requires regular toileting, and laxatives and suppositories are likely to be necessary with a low roughage diet for lesion above L3. Scoliosis monitored and may require surgical treatment. Ventricular dilatation associated with the Chiari-2 malformation is often present at birth, and 80% of affected infants require a ventriculo-peritoneal shunt. It's given VP shunt for progressive hydrocephalus during the first few weeks of life. The most severely disabled have a spinal lesion above L3 at birth. Unable to walk, have scoliosis, neuropathic bladder, hydronephrosis, and frequent developed hydrocephalus. Modern medical care has improved the quality of life severely affected children. Their care is best managed by specialist multidisciplinary. Recently, fetoscopic surgery to repair the myelomeningocele in utero in the late mid-trimester of pregnancy has been performed on selected fetuses in a few specialist centers. This may reduce the need for ventricular shunting and improve neurodevelopment outcome, but carries risk of preterm delivery. Includes encephalocele, spina bifida occulta, meningocele, myelomeningocele. UK birth prevalence has fallen recently due to natural decline in antenatal screen. The birth prevalence is reduced by periconceptual folic acid. Myelomeningocele may cause lower limb sensory loss and paralysis, dislocation of face, telepiece, equinovarus, neuropathic bladder and bowel scoliosis, and hydrocephalus from the Chiari-2 malformation. Hydrocephalus is accumulation of cerebrospinal fluid in the brain and infiltration. This can be congenital, associated with cerebral anomalies or obstruction to the flow, leading to dilatation of ventricular system, proximal to the site of obstruction. Obstruction will be within the ventricular system, or aqueduct, obstructive, or at the arachnoid villi, the site of absorption CSF communicating and cause obstruction in the ventricular system, congenital anomaly, aqueduct stenosis, Chiari malformation, greater transformation through foramen magnum, posterior fossa neoplasm, or vascular malformation, intraventricular hemorrhage, and preterm infant. Communicating hydrocephalus failure to absorb CSF, subarachnoid hemorrhage, and meningitis, pneumococcal tuberculosis combined microcephaly feature in infants with Hydrocephalic skull sutures have not fused. The head circumference will be disproportionately large or show an excess rate of growth. The skull sutures separate and the diaphragmal blood bulges and the scalp wing becomes engorged. Advanced signs fixed downward gaze or sunsetting of the eyes. Older children can develop signs and symptoms of raised ICP and hydrocephalus may be diagnosed on antenatal ultrasound. Scanning. For suspected hydrocephalus, initial assessment is with cranial ultrasound infants or head MRI. The head circumference should be monitored over time and plotted on a centile chart. Treatment is required for symptomatic relief of raised intracranial pressure and to minimize the risk of neurological damage. The mainstay is insertion of AVP shunt, but endoscopic treatment to create a ventriculostomy is sometimes preferred. Shunts can malfunction due to blockage infection, usually with coagulase negative staphylococcus. They then need replacing or revising. Overdrainage of fluid can cause low pressure headaches, but the insertion of programmable valves can help avoid this. Hydrocephalus in infants presents with excessive increase in head circumference, separation of skull sutures, and bulging of anterior frontal eye, distension of scalp veins, and sunsetting of the eyes. Other children present with symptoms of intracranial pressure. Treatment is usually with the ventriculoperitoneal shunt. VP shunt for teenage symptomatic. This is crossing large head and downward deviation, sunsetting eyes from untreated. This is burr hole, reservoir valve, peritoneal catheter, most common, and right atrial catheter is uncommon. Extra length to allow for growth. Symptomatic hydrocephalus, sufficient length of shunt tubing is left ventricular cavity to allow for the children growth. Right atrial catheters require revision of growth and have more complication. Neurocutaneous syndrome with neurocutaneous nervous system. This can have a common ectodermal origin. And immunologically, disruption causes syndromes involving abnormalities to both systems. Neurocutaneous syndrome. First one is neurofibromatosis type 1, affects 1 in 3,000 live births, autosomal dominant, highly penetrant condition with variable expression. It is caused by mutation in neurofibromin NF1, which arises in about 50% as a de novo mutation. To make the diagnosis, two or more of these criteria need to be met. 6 or more careful late spots greater than 5 mm in size before puberty, greater than 15 mm after puberty, more than one neurofibroma, a firm nodular overgrowth, or of any peripheral nerve. This is careful patches, X-ray freckling in neurofibromatosis. Axillary freckling, optic glioma, which may cause visual impairment, one-lash nodule hematoma of the iris seen in slit lamp examination, bony lesions from sphenoid dysplasia, which can cause eye protrusion, first degree relative with an F1. The cutaneous lesions tend to become more evident after puberty, and there is a wide spectrum of involvement from mild to severe. Neurofibromata appear in the core form of any peripheral nerve, including cranial nerves. They may look unsightly or cause logical signs if they occur at the site where a peripheral nerve passes through a bony foramen. Visual or auditory impairment may result if there is compression of the second or eighth cranial nerve. Megaencephaly with learning difficulties, epilepsy are sometimes seen. Neuropathy type 2, multiple inheritance schwannomas, meningiomas, and pneumoma is less common. Autosomal dominant syndrome causes mutation in two genes usually presenting in the adolescence, and about 50% due to the no mutation by later acoustic neurometa. Are the predominant features and present with deafness, sometimes as cerebellar pontine. Angle syndrome with the facial, seventh nerve braces, and cerebellar ataxia, both NF1 and NF2, can be associated with endocrine disorders and the multiple endocrine neoplasia syndromes. Okay, this is almost done. Other associations are few chromocytomas, pulmonary hypertension, renal restenosis with hypertension. Rarely the benign tumors undergo sarcomatous change. However, most people with the disorder carry no features other than the cutaneous stigmata. Tuberculosis is prevalence of tuberculosis 1 in 9,000 live, which are autosomal variable penetrance and up to 70% mutation rise de novo. The cause of the mutation is TS1 and TS2 genes. Facial angiofibromas. In tuberculosis, cutaneous features consist of depigmented ash-leaf-shaped patches or a melanotic nevi which fluoresce under ultraviolet light, was light. Roughened patches of the skin, shagreen patches usually over the lumbar spine, angiophragmatoma, adenoma, sebaceum, in a butterfly distribution over the bridge of the nose and cheeks, which are unusual before the age of 3 years. Logical features are seen in 50%, including epilepsy, infantile spasm, or focal seizures, usually associated with intellectual disabilities and autism. Other features include fibromata beneath the nails, subungual fibromata, dense white areas on the retina, pancomata from the local degeneration, rhabdomyomata of the heart, which are identified in the early weeks of life on echo, but usually resolve in infancy. Angiomyolipomas and polycystic kidney cysts in the lungs and brain, even if asymptomatic, there are subendymal and ependymal nodules in cortical tubules. The subependymal nodules may enlarge over time and form subependymal giant cell astrocytoma, which sometimes block the flow of CSF, causing headache, vomiting, hydrocephalus. Many people who carry the gene have no stigmata. Other than the cutaneous features, there are no associated neurological features. CT scan will detect the calcified subependymal nodules and tumors in the second year of life, memorize more sensitive and more clearly identify solutions. Sturge-Weber syndrome is a sporadic disorder with the hemangiomatous facial lesions of Port-Weinstein and distribution of trigeminal nerve associated with a similar lesion intracranially. Ipsilateral leptomeningeal angioma. In the more severe form, it may present epilepsy, intellectual disability, and a contralateral hemiplegia. The ophthalmic division of the trigeminal nerve is always involved. MRI is the imaging modality of choice. Children presenting with intractable epilepsy in there is Port-Weinstein and the distribution of trigeminal nerve. Early infancy benefit from hemispherotomy. Laser treatment may be used to lighten and remove the Port-Weinstein. For children who are less severely affected, duration is unusual after the age of 5 years, although they may still be seizure and learning difficulties. There is high risk of ipsilateral glaucoma, 50% children which should be assessed in the neonatal period. Neurodegenerative disorder, these are disorders that cause a deterioration in motor intellectual function. Abnormal logical features develop, including seizures, spasticity, abnormal head circumference, micro and voluntary movement disorders, visual and hair loss, behavioral change. While usually rare, they are numerous and include many inborn. They are discussed. Developmental regression or reported loss of previously acquired skills should prompt investigation of the cause. The most commonly encountered neurodegenerative conditions are lysosomal storage disease, mucopolysaccharidosis type 3, in which absence of the enzyme leads to accumulation of hormone metabolic within the lysozyme. These disorders often have organomegaly associated with them. Peroxisomal enzyme defects in adrenoleukodystrophy. Peroxisomes are catalysts and oxidase contain organelles involved in long chain fatty acid oxidation. Sign deficient can lead to accumulation of very long chain fatty acids. It's a disease from accumulation of copper may cause changes in behavior and additional involuntary movements or a mixture of neurological and pediatric syndromes. Leukodystrophy MRI can identify many degenerative, often life-limiting, shortening genetic diseases affecting predominantly the myelination of white matter in the brain. Once suspected, some can be diagnosed by white cell enzyme assay and or other biochemical tests, but increasingly reliance is placed is placed on DNA testing, Krabbe's or adreno leukodystrophy LD are just two examples. Folio tissue MRI can also MRIs can also assist in diagnosis and degenerative disease affecting predominantly the gray matter in the brain. These include the neuronal ceroid lipofuscinosis, Alpers, and the fatal complication of measles subacute cirrhosis SSP. This was almost eradicated in many countries by immunization, but has reemerged some countries following reduced uptake of the measles vaccine. SSP presents 6 to 8 years after measles and peaceful childhood with progressive dementia, dystonia, and visual impairment, and characteristic periodic jerk best identified on EEG. So these are presentations, neurodegenerative or infantile. These are a bit difficult. A02 infantile neurogen ceroid lipofuscin Fucinosis, developmental risk by end of first year, seizures and blindness, tribal leukodystrophy, irritability, hypotonia, myoclonus, and Rett syndrome is regression by 6 to 18 months with restricted hand wringing, and Tay-Sachs is hypotonia, seizures, and blindness. It is diagnostic is for infantile neuronal NCL, skin biopsy, blood enzyme analysis. For tribal leukodystrophy, we do white cell enzymes, and for Rett syndrome, we do DNA testing. Tay-Sachs, we do white cell enzymes. Age 2 to 5 years, mucopolysaccharidosis type 3, late infantile NCL, and Alpers. In developmental delay, behavioral differences and dysmorphism, and we do urinary gags and white cell enzymes. In late infantile myoclonus, motor difficulties and blindness, skin biopsy, enzyme analysis, DNA testing. In Alpers, seizures, developmental regression, hypotonia, and hepatic derangements, and this is DNA testing. Juvenile LCL, adrenoleukodystrophy, and Niemann-Pick type C, and Frederick ataxia. It has cognitive and motor decline, visual deterioration, seizures later, speculated lymphocyte on light microscopy, fingerprint and electron microscopy, DNA testing. Adrenoleukodystrophy is cognitive development, visual impairment, seizures, VLCFA, very long chain fatty acids, and DNA testing. And Niemann-Pick seizures, vertical gaze, and oxysterols and DNA testings. Frederick ataxia, pyramidal signs, and peripheral neuropathy, age 12 plus in Wilson disease, liver disease, extrapyramidal movement disorder, and tremors, and plasmapopper and cerebroplasmin and DNA testing. Juvenile Huntington's, progressive dystonia, dementia, seizures, and corticospinal tract signs. So this is it for neurological. Thank you.